Psychiatric and Behavioral Emergencies. You're still listening to Barton Community College EMS Education preparation for the Module 2 exam. This is the topic that I have a lot of passion for, is dealing with psychiatric and behavioral emergencies. You know, my saying is you got to be a little bit crazy to deal with crazy. Because if you're not crazy, you can't put yourself a little bit in their shoes to understand what's going on. And psychiatric problems is not that we've got a problem with the delivery of the blood to the brain, or that we have issues with the respiratory system or the cardiac system or the gastrointestinal system. Psychiatric emergencies is there's an issue inside the components of the brain, how all the wiring and everything is communicating with each other. And what does this result from? It results from things that we call stress. Stress and anxiety is one of our biggest issues that cause psychiatric emergencies. And stress causes issues. Stress causes so many issues that we don't always think about, as well as the physical trauma that can cause stress, or drug and alcohol abuse that can cause stress, or psychiatric conditions that are coming from stress. Stress affects not only our body, our mind, our behavior, and our emotions. As you notice over here on the left-hand side of this screen, the amount of things that stress has caused issues with is crazy. So we wonder why individuals have problems when it comes to psychiatric issues. Now, there's a difference between psychiatric issues and behavioral issues. A behavioral emergency is a manner in which a person acts or performs, which is behavior. And a behavior emergency is the behavior that they act in a given situation that is unacceptable or intolerable to the patient's family, the patient, or the community. Now, we also understand that we're going to talk about several different psychiatric conditions, but we also need to understand that with these issues, we need to make sure that we understand that sometimes these individuals are going to be a threat to themselves or others. So if they're a threat to themselves or a threat to other people, we might need to possibly use things called restraints. And we have soft restraints and hard restraints, and we definitely want to stay away from using handcuffs. Now, always go back to what your instructor has taught you on using restraints, but the thing about restraints is we use restraints when they're a threat to themselves or others. And if we can, if you have an ALS provider and you need to use restraints because they're going to be a threat to themselves or others, then you might need to use a chemical restraint. Chemical restraints are a little bit easier to deal with, and they don't fight as much, and that fighting can cause an increase in respiratory, an increase in tachycardia, and it cause more issues. But one of our psychiatric conditions is anxiety. Anxiety can lead to panic attacks. And panic attacks are a real emergency. And our biggest thing is to be there for the patient and help them to try to calm down. We may not get them calmed down in 2 minutes, so you need to realize that we may be on scene for just a little while trying to help these individuals out. So just keep that in mind. We also have things called bipolar disorder. Bipolar disorder, bi meaning two, and polar meaning opposites. We have polar opposites, two polar opposites. We have manic phase and we have a depressive phase. Your mania phase is like we talked about, your downers and uppers. You know, one is going so fast and the other one is so tired. Just can't move. If you've seen Winnie the Pooh, you would understand the bipolar disorder through the view through the 100-acre woods. Because Eeyore is our depressive. Eeyore is the, woe is me, I guess I'll go over here, take a load off. Where our manic phase, our elevated mood, our I'm going to get everything done, I'm going to do this, and T-I-double-G-G-G-E-R, Tigger, is our manic phase. And so looking at bipolar disorder, we can look at Winnie the Pooh and understand through his friends Tigger and Eeyore the differences between mania or manic phase and depressive phase. And then we have something called schizophrenia and paranoia. Schizophrenia is where they just have this separation from reality, and their neurodevelopment is affected, and this can come from trauma. And they have a dysfunction from their emotions. They feel some emotions in some instances and other emotions in others, and it's not the right emotions. There's a common misconception that schizophrenia, it means that they have multiple personalities. That's not what we're talking about. If they had multiple personalities, it would be multiple personality disorder. You could have both of these together, and when we have one psychiatric condition, it's very possible we have another psychiatric condition. But we also need to understand about our depression. If we have anxiety, we can lead to other disorders like depression, where they can become suicidal, and we need to be watching for suicidal tendencies. We need to be watching for our panic attacks, which are that sense of dread, the rapid heartbeat, and we're going to see this in our vital signs. And so we also need to be looking for paranoia. Now, our paranoid individuals, they have obsessive compulsive behaviors, they have negative symptoms, they have emotional symptoms and hallucinations, and they're seeing things that aren't reality. They're believing things that aren't reality, and they think that something is going on that isn't reality. And so they're paranoid about it, and they're checking the lock 20 times in the night because they think somebody's going to unlock it. They think that, what something is said by an individual that is meant one way, they think it's meant another way, and that they're a threat on their life. And so, as I said, you could have one with another. So you sometimes see schizophrenic paranoia together. You see depression and anxiety together. So one psychiatric condition can lead to another psychiatric condition. And some of these are resultant of drugs, emotional abuse, traumatic abuse, physical abuse, or just a genetic predisposition. And then finally, we have to watch for our suicidal behavior. And the number one thing I say when it comes to suicide is watch for the signs and symptoms of suicide, where they have increased alcohol abuse, they're aggressive, they're impulsive or reckless. But you also need to be able to ask the questions. Ask those good questions of, are you going to hurt yourself? How are you going to hurt yourself? Are you having thoughts of suicide? Be honest and open with these individuals, and they'll be honest and open with you. And the number one population that not everybody remembers, that is the suicidal population that gets it done, not that I want them to, but the population that commits suicide that is successful is our geriatrics. And it's always, always, always around the holiday season. Why? Because families have forgotten about them, or it seems like the families have forgotten about them, and when they do it, they want to do it right. And they don't want to have a half-hearted attempt. And I say half-hearted, and it makes it seem like we want them to be successful. We don't want them to be successful, but I also don't want them to attempt it in the first place, where they have debilitations after committing suicide or trying to commit suicide. Your psychiatric conditions, your behavioral emergencies are issues. And when we talked about drugs earlier, the excited delirium kind of presents with a little bit of the paranoia. Your excited delirium, individuals are having an extreme tachycardic heart rate, they have an increased blood pressure, and it's probably due to the drugs and alcohol that they have taken into their body, causing this excited delirium, like K2 or bath salts. And in those individuals, a chemical restraint is very good because it is a life-saving measure. And so that recognition, rapid transport, if not ALS help to chemically sedate that individual, is going to help bring down their heart rate and help bring down their blood pressure. Not every time do we want to do that, but in the excited delirium where they're also hyperthermic and they're going to have an increased body temperature, we need to do it, because if we don't, they could go into cardiac arrest. I hope this helps you guys prepare for psychiatric and behavioral emergencies and give you a little bit more rundown. And working through that work study guide is just going to help you become a more well-rounded EMT preparing for that Module 2 exam, as well as preparing for your certification at the end of this course. Good luck and have a great week.